All right, I want to welcome everyone to the annual LeCocq Lectures. I'm Alexis Velikov. I'm the Chief of Orthopaedics here at Swedish. I'm actually a graduate from the UW. I actually also did my spine fellowship up at UBC. So it's my pleasure today to welcome Dr. Graham King. A little bit first about the LeCocq Lectures. For those of you who don't know, Dr. LeCocq is actually one of the people who started orthopedics here in the Northwest. Born in 1896, he came to the Northwest. He actually did his MD in Oregon. Actually started at the Shriners Hospital there in Portland, Oregon, and he was actually one of the founding members of the University of Washington's medical school. Was a professor in orthopedics here until his death in 1966, and as a bequest from his family, this lecture is in his honor. He started a clinic that used to be called the Seattle Orthopaedic and Fracture Clinic, and when I finished my fellowship, my first job was at the Seattle Orthopaedic and Fracture Clinic. So he has done a lot of research, did a ton of stuff throughout the beginnings of orthopedics, and if you look at it, it was really sort of the dramatic changes that happened in orthopedics. I mean, if you think about fusion started in sort of 1911, and if you look at modern orthopedics and AO, he was basically a professor during the rapid changes of orthopedics. So I think it's a great thing to look at the Northwest and look at the advances he made. And in honor of that, we have these annual lectures, and this year we've brought in Dr. Graham King. He's a professor of hand surgery up in the north. Dr. King did his MD degree at UBC, and since he's from Canada, by the way, those who don't know, those are the Canucks, okay, so for the hockey teams. Did his orthopedic at the University of Toronto, that would be the Maple Leafs, right? Did his fellowship at the University of Calgary, right? Flames, noticing a little pattern for where he's going. And then actually did a subspecialty training and did some fellowships at the Mayo Clinic, and that's the Wild, I believe, right? I get that right? And then now he's a professor at the University of Western Ontario, and we were just talking about it. Not only do they have a team, well, they're back to the Maple Leafs or maybe the Senators, but they have their own Ontario Hockey League there, and he's done incredible amounts of research. Last night we had some great talks about his work with industry and development of radial head arthroplasties and total elbow arthroplasties. And so it's my pleasure to welcome him here. He's going to be talking about the osteoporotic distal humerus fracture.
Well, thanks very much and good morning. I live in London, Ontario, so I didn't put the map up this morning. So if you want to talk hockey, we're right between the Red Wings and the Leafs. So it turns out, even though we're Canadians, we live right between the American team that actually is pretty good, the Wings, and the Leafs, who remain pathetic after 20 years. So there's probably a lot more Red Wings fans in London, and it costs about half as much to go to their games as it is for the Leafs. So I still like to go to the Red Wings games because I understand hockey. Anyway, we're going to talk about osteoporotic distal humeral fractures. I thought this would be a good topic, primarily, for the residents, and also kind of update those people in practice. I think the landscape there is changing a little bit in terms of the numbers of patients we're seeing. The evidence says that this is becoming a more common problem in our practices, not just distal humeral fractures in high energy trauma, which is probably not actually changed all that much. It's really the fragility fractures that are challenging our abilities as orthopedic surgeons to manage these patients. And I thought I'd go through the various treatment options because sometimes people forget there's other ways to treat these fractures than a plate and screw. I do have some relevant disclosures for this particular talk, but I'll try to avoid that as much as I can. So I think when you're thinking about someone with the distal humeral fractures, there's really kind of three main treatment options. You can treat them non-surgically, and I think that's an important thing to remember, particularly for those of you that are going up for your board exams and checking those boxes. Remember that is an option, and whenever you're seeing an elderly patient with a distal humeral fracture, it's a little bit different than a hip fracture. There's not good evidence that we're saving someone's life by fixing their distal humeral fracture, which is different than someone with a hip fracture. So pinning an 80-year-old's hip fracture makes good sense, but sometimes we can get rid of people that you didn't want to get rid of by mistake operating on elderly people with distal humeral fracture. So you make sure you have that conversation with the patient and their family, because if things don't go well, you want to make sure that everyone understood what the options were if you decide to operate on them. And then when you're thinking about surgery, I think, of course, the option to fix it or replace it. Now, in terms of non-operative treatment, when do I think about that as a role for a patient? I think about someone that really isn't fit for surgery, and you really have to assess that. Sometimes it's hard when, someone gets rolled in on a stretcher to understand to what level they're participating in society, what's their mental status, because of course once you're in the hospital a day or two, that mental status may change. So you really need to make sure you understand that, talk with the family, don't kind of write someone off just because they're 90, that they can't have an elbow that works. If they were living independently before they fell, otherwise their health is pretty good, that's not a contraindication to fix their distal humerus or replace it. So understand what that is by careful history. You need to look at what their demands are. If they truly have severe dementia, like sadly my mother does and lives in a nursing home, and someone gets her up out of bed and puts her in a chair, if my mother broke her distal humerus, I would not have anyone operate on it, because she doesn't really need her distal humerus, someone else feeds her, so sadly. But that's the kind of thing you need to know before you decide. And I think then the question is, should you treat it with a bag of bones? And this is kind of the way I think about it currently based on some work we've done, is if there's no column contact of the distal humerus, then probably trying to get that to unite is unlikely to be successful. So we typically will give that kind of a patient a collar and cuff and treat them with a bag of bones. But if someone has column contact, we'll treat that with cast immobilization, which again is maybe a little bit different than, I'm not sure what you're taught here, but we've actually found that to be reasonably effective, as I'll show you. So when we've got someone like this who's got a lot of medical comorbidity, she's 90, but really, she's an ASA 3.9, she's not a 4, but pretty darn close. And she really is, very low demand. She lives in an assisted care facility, and we decided after discussion with the family to treat this non-surgically. Now, she's not able to tell us if she's uncomfortable. And that's the other thing that's important. So you don't take someone like this that can't tell you there's something wrong and put them in a cast, because then you may hit some problems with pressure sores, or even the bone may come through the skin into the cast and you might not know that. So this type of patient, we're very much try to avoid cast immobilization. So we put her in a collar and cuff, and here she is at follow-up with a non-union of her distal humerus, but you can see there a little bit on her face. She doesn't seem to be bothered by that, and this has recently been published, and I think one of the residents yesterday presented that paper by Aitken from Scotland, who showed a fair outcome for patients that were treated with that, but their dash is pretty lousy, a dash of 38. Certainly none of us here would want to live with a dash of 38. It should be around 5, so that's kind of not very good. That said, these patients were mainly satisfied in that population. Their mortality rate was actually about 50% at 4-year follow-up. So the patients that were chosen for this were very unwell, and I think it's an option to consider, and particularly on your board preparation, you need to make sure you understand this as an option, because if you decide to operate on it and things don't go well, you need to understand what you might have done next time. Now this patient here is a little different. She again, has had a stroke in the past, a heart attack. She's on chronic Coumadin treatment, and she's got a distal humeral fracture which is displaced, but there's column contact. For this kind of a patient, we've actually found it very successful to cast these patients. This patient, I know this sounds crazy, was kept in a cast for 8 weeks. And you would say to me, and I don't know if there's any therapists here this morning, but that's crazy. She'll never move her elbow again, but you can see here, that's her range of motion. Not perfect, but actually it's pretty functional for her. But sometimes it doesn't work. We thought this would work. It's a minimally displaced supracondylar fracture. I don't know if you can see it there, kind of coming across here. Extra-articular, but he's got some pre-existing arthritis, which may make it a little more likely that he'll get a non-union. So we actually did treat him in a cast, and he got a non-union. So that's about 20% of patients we've treated in a cast like that will get a non-union. But the good news is, if that's symptomatic, that can always be salvaged with a replacement. So you haven't really burnt a lot of bridges. I can tell you that elbow replacement is a lot different than if you do an elbow replacement, as we talked yesterday, with a bunch of broken plates and screws. That one's almost like doing a primary elbow replacement versus an elbow replacement where someone's tried to fix it and it's fallen apart. So what's been our experience with cast mobilization? Over a 6-year period, we reviewed our cases, 32 patients. So it's not that uncommon we might do this, and you might say that's a Canadian healthcare system you can't afford to operate. Well, that's actually not true. We're actually pretty good at fracture care, we're just not good at elective care. And so patients like this, we could have operated, but for whatever reason, the patient, the family are together, we chose to treat them non-surgically. So they were treated between, on an average of 5 weeks in a cast, and this was published in JSES last year. Their age was quite variable. We had one patient that was 47, but was really a medical nightmare, and after discussion, treated non-surgically. And it was a typical group of patients. Actually, most of them were living independently, but they were all mainly retired, and 90% of the patients had significant comorbidities. Interestingly, I never thought this would occur, but 81% of our patients united their distal humeral fractures with cast immobilization. Union was more likely if they had column contact like this, and this is actually quite similar to a report by Robinson in 03. So 5 of them got a non-union, 22 united. When we looked at their functional outcome, I won't go through this in detail, but basically their pre showed minimal disability, so 16, and their other scores were quite good. An MEPI of 90, that's pretty good for distal humeral fracture. How does this compare with the literature? Well, it's pretty much the same. So whether you do a total elbow, an ORIF or R series, the range of motion, flexion extension, and their MAYO scores were identical than if you operated on them. So that's kind of interesting that you can actually give someone a cast and not give them a $3,000 implant or $2,000 worth of plates, and they can have the same functional outcome. That's kind of an interesting finding, which I think the insurance companies may be a little interested in. Complications, well, we did have one complication, and that was a patient that got a cast sore, as you can see here. And so if you do treat these patients in a cast, if they're bony, you need to bring them back. It's not like put on a cast and I'll see you in 8 weeks or 5 weeks or 6 weeks. You actually check the skin every now and then, particularly if they're not quite as cognitively intact. One patient failed and had a poor outcome, so as I showed you, sometimes you're going to treat these non-surgically and you'll have to do something later. But we didn't have any infections, we didn't have any ulnar nerve problems. And how does this compare with the literature? Well, if you have a total elbow, you have a 33% chance of a complication, and ORIF is almost identical. The complications are different, as we'll talk about, but it's 33% versus 3%. So it's quite a bit different if you decide not to operate on them. Union rate, as shown, Robinson found an increased risk of non-union and delayed union with non-operative care, and we found an 83% union rate. Operative union rate, of course, is more like 97%. So there is a difference, and so I think but it is a useful thing to talk to patients about before you make a decision to go ahead and just fix their distal humeral fracture because it's broken. I think that's a real important message for you today, to at least have this discussion with the patient and family before you do an operative management plan, because that may sway what their decision making might be. Of course, most patients with distal humeral fractures, even the elderly, are treated with ORIF, and these are patients that are fit for surgery. They can able to tolerate an operation which may take between 2 and 5 hours. They desire to remain active. So these are patients that want to keep working. In our population, I live in basically a farm belt, and the farmers, just because they're 70 doesn't mean they're not farming. They keep farming until they can't do it anymore. So particularly the men are completely non-compliant. And they continue jumping up on their combine and getting out in their tractor, and so these patients aren't a candidate for an elbow replacement, even though they might fall into that 75-year-old where you get a total elbow. Be careful. So the other thing is, of course, you have to say the fracture can be fixed with ORIF in some way, and I actually tend to fix more males that are older than females, just because of that discussion I just talked about, that the activity level and compliance may be a little bit different, but it really depends on the patient, and I think you have to have a very good conversation with the patient to help decide. So don't just use an age to say 70 you're getting a total elbow and 65 you're getting ORIF. I think that really is something you need to consider carefully. Every patient's different, as we know. So what are the principles? Well, these are pretty well laid out, and the AO and other groups have looked at that. Restore the joint surface. For me, I always tell the residents I like to get 3 screws, in both sides. So 3 screws on one side, 3 screws on another into the distal fragment. If that works for me, those screws should preferably go through a plate if possible, and those screws should be as long as possible. We want to compress the supracondylar component, and I think the other thing is you need to use robust plates if you have shaft extension. So fractures which go up very high, the recon plate starts to kind of not be as good an option, and then you want to use either DCP plates or some of the more patient-specific pre-contoured plates. I think orthogonal plates have a big role to play in younger patients, but in this group of population that I'm talking about, osteoporotic fractures, we tend to primarily use parallel plating for that group of patients. So on someone like this, she's 63. This is not going to be a particularly easy fracture to fix. We had a discussion yesterday, do you get a CT scan or not? I think, it depends on your comfort level with interpreting this x-ray. I mean, I think for me, I probably don't need a CT scan because you can see the trochlea and the capitellum are largely connected. And the epicondyles are not. So this gives you an idea that this has probably not got a lot of blood supply, that trochlea. That said, she's only 63, and I certainly don't want to do a total O on a 63-year-old. And so the CT scan just tells you that's one big piece. So that's the good news. The joint surface is fairly straightforward. And because of that, when you're thinking about surgical approach here, it's not an intercondylar fracture. It's actually primarily a transcondylar fracture with the epicondyles knocked off. So this can be treated with a paratricipital approach, which is what we did. And we typically use that for type A and simple type C1 fractures, as we talked yesterday. And so she was treated with parallel plating. You need to use a plate that goes around the epicondyle in this kind of a low transcondylar fracture. That's always a bit of a pain, that plate, because even the pre-contoured plates don't always perfectly fit there. So you may have to do a little fooling around even with pre-contoured plates, or if you use a recon plate, that requires some expertise in plate bending. I'm not sure what it's like here now, but Daphne, are the residents, do they get to bend a lot of plates? Yeah, I think it's a bit of a lost art because a lot of things we fix now, we take a plate off the shelf and just lay it on like a distal radius. We don't even think about bending the plates anymore. But these kinds of fractures, sometimes you have to bend the plates, and you have to be prepared to do that and know how to do it in a timely fashion, because it does take some time to get it right. Another example here, this is a more complicated T-condylar fracture. Again, she's 64, but this is a fragility fracture. She has undiagnosed osteoporosis, and you know that the screws aren't going to be great here. But again, I think with a sandwich type parallel plating approach with this, it can be quite helpful. The CT scan really doesn't help you because you know you're going to do an olecranon osteotomy anyway. I think the other thing, sometimes people worry about doing olecranon osteotomies when one of the bailouts might be a total elbow, but as we talked yesterday, I don't think that should dissuade you from doing the right surgical approach to treat this. Even if this falls apart and you've done an olecranon osteotomy, as we did here, then you're still going to be okay to salvage it with a total elbow. So this was treated with a chevron osteotomy. It's an older case now, but I use a transverse osteotomy, as explained, and then this is parallel plating. You typically plate all my osteotomies. We talked a little bit about that yesterday. We reported this in JOT in 07 sequential series. I think it was 18 or 19 patients treated with a plate fixation for the osteotomy without any failures. And so that kind of is fairly effective for us. The important thing is when you're using a plate on the osteotomy, make sure it's pretty low profile so it doesn't stick up, because certainly plates eroding through the skin over the posterior elbow is a big problem in the elderly patient. And this is a guy who fell off his tractor. This happens to be an open fracture, and it's pretty smashed, and it does extend relatively high on the columns. I don't get a CT scan for this, but it was resident did it before I could intervene. Just slows you down getting to the OR. And again, we put a whole bunch of plates on here, as you can see, and you might say you're crazy, King, and Daphne would know that that's probably true. But I think one of the little tricks that one of my mentors taught me, and I don't know if Daphne uses this, but this is a little 1/3 tubular plate. So sometimes, you got all your clamps on, you can't actually put the plate where you want because the clamps are all in the way. So that's a good little trick, just to put a little 1/3 tubular plate on to hold the column in place. Because, putting K-wires or Steinman pins up to hold these, I don't find it works very well. So I put a little plate like that on to hold things, and then I put the proper plate on. Sometimes I take them off, sometimes I leave them on. You know, I don't think it really matters, but sometimes those can be useful positioning plates. And here we actually shows triple plating. And he went on to Unite. Now, you know, there's certainly lots of technical things that you may see coming through, where this is a 77-year-old lady, and she was treated with recon plates. And this fracture is relatively high, right? And so this is, I always tell the residents, a fracture above the olecranon fossa is like a subtroch fracture. When you're thinking about that in the femur, you know that's a problem fracture in the femur, tends to get non-unions, and that's where the non-unions tend to occur in this population, not at the intercondylar level. So this is kind of old AO technique, 90-90 plating. It's actually relatively well done, I think, but we've learned that probably those screws there are blocking getting proper screws across into the joint surface here, and those plates aren't strong enough to manage that kind of fracture, so that's probably going to fail, which it did. So those plates are too weak for that particular fracture, although they can be fine for low supracondylar fractures. This guy fell off a bike, open fracture. There's probably not too much right about this. I mean, I think that we would all agree that putting plates on the posterior humerus to manage a distal humeral fracture are just not good, because a patient lifts their arm up like this, and the first thing that happens is the screws pull off and out, as this happened on the lateral column. And so this ended up revised. It's an old case, so we were using DCP plates for revisions there. Those are hard to contour, but it actually does work. Another example, plates both on the back. You know, I got lots of these I could show you. You know, you just have to follow the principles and you won't end up with this. I mean, so salvage with the total elbow. Another example here of things not much really done right here. I guess they did the osteotomy united, you know, but this kind of a problem is, you know, the plates just aren't the right plates for this problem, and, you know, you need to have the appropriate things available to fix these fractures. This guy was pretty miserable, you know, his arm goes like that, and, you know, there's not much good about it. So it goes sideways. Yeah. So he was treated with revision ORIF. So, you know, he's a younger guy. You want to do a humeral shortening, bone graft, and treat him with some plates that are appropriate for the problem. Never did get this screw out of his radial nerve, but his radial nerve was still working, so we left it there. So what about ORIF in the elderly? There are specific papers written on this topic, and you can look them up. They're referenced down here. But 85% of patients will have a good to excellent outcome with ORIF of a distal humeral fracture, even in the elderly. A nice paper from Ring's group showed that if they united, the results are pretty good over long term. So it's different than a total elbow, which is a ticking time bomb. If you get these to unite, you're pretty much done, right? Sometimes their hardware bugs them, other kinds of things, but pretty much you're done. Most achieve union and a functional range of motion. The failure rate's certainly higher, and actually the smoker and the obese smoker are the ones that give you the most trouble. And so those are patients that you may want to kind of consider when you're deciding between elbow replacement and distal humeral OIF. You know, which are you going to do? It's actually, those are the factors which tend to be something you want to think about. Not just the classic things you talk about. I mean, we always think about that in the tibia, but certainly in the elbow, it's a lot on another important factor. The really heavy-set patient has a much higher failure rate with ORIF. Unfortunately, they also have a higher failure rate with a total elbow, and so that doesn't help too much. The complication rate is, however, high, and it's 30% in most series, and ulnar neuropathy and non-union are the two biggest ones that come to mind. What do I think are the kind of pearls when you're thinking about ORIF? I think you want to, first thing is choose the right surgical approach. You know, there's this big push to do paratricipital approach, not do the osteotomy, but then you get yourself into a situation that you're wasting time. You know, you're 45 minutes into the case, you've got the nerve out and you're fooling around, you can't get the reduction, and then it's an hour and a half and you still haven't got anywhere. That's not a good thing in an elderly patient. You don't want to spend 8 hours, 7 hours, or 6 hours, as people have called me and said, I said 7 hours trying to fix this distal humeral fracture in this 80-year-old. And you think, oh my God, you know, that's not what you want to do. You want to be efficient with your surgery because you're going to get them infected. There's health issues that go along with a long surgery like that. Don't be afraid to do an olecranon osteotomy, even in the elderly. They heal, whether you do it with a tension band or plate or nail or whatever you like, or screw. You know, as long as you do that technically well, they usually heal. Your plates, basically the 90-90 plating, I think for this stability fracture probably should be more or less abandoned. I think it does work and I was trained that way. I'm trained by the AO gurus, Tile and Schatz, who wrote the books. But, you know, that has not worked well for me in the elderly patient with a distal humeral fracture. I think it works fine for the young trauma patient, but in the elderly patient, you should use parallel plates. That should be your default plate for this kind of population, and you'll be much happier with your outcome. What are the big controversies? I think surgical approach, when in doubt, do an osteotomy. You can still do the total elbow even with the osteotomy there. Don't fret about that. The ulnar nerve, I don't know. You know, we can maybe talk about that. I mean, I know there's randomized trials going on. Obviously, I'm a upper limb surgeon. I look at the ulnar nerve every day. For me, I move the nerve, but other people are afraid of the ulnar nerve and they have more trouble with it. I like to get the nerve off the plate. Other people put it back on. I don't know the answer to that. I know there's randomized trials going on, and I think, you know, just because one randomized trial show it's safer not to touch the nerve, that may not be the case in your own personal hands. So I don't know the answer. Certainly as a revision surgeon, I don't like the nerve sitting on the plate, but you know, we don't know the answer to that question. I still move it. Heterotopic bone prophylaxis in the elderly patient, shouldn't use any for sure, because we know radiation increases their non-union rate, probably increases their infection rate, and you don't want to give indomethacin in the elderly patient. You can actually knock them off giving them that drug. So even though we might consider it in a young patient, we talked about that a bit yesterday, don't even think about it in this population. Now it's interesting, they do get a lot of heterotopic bone, but that's just something you can't really control. Most of it doesn't affect range or motion or outcome. Rehab, we like a lot of extension splinting in this elderly population. So when I'd fix a distal humeral fracture in the elderly, I actually put them out in extension to take the tension off the posterior wound, and I actually don't let them move for 2 weeks, and I keep them in that position. Sometimes a therapist freak because they don't think they're going to get their flexion, but surprisingly people do get their flexion back. They struggle more with extension, but after the 2 weeks when the wound looks good, we'll let them flex. And I've had a lot less wound problems since I stopped moving the elbow and I've used extension splinting. So what about total elbow replacement? I think this is kind of popular, it's fun, and there's a big trend to use total elbow arthroplasty in this population. So we consider that when the patient's still fit for surgery, they're active mentally, physically, but they're not too active, so they can understand what this restriction might be. So 10 pounds isn't much, and that means no golf, right? I don't think you should golf with a linked total elbow, which is what these people get. You know, if you're a farmer, you know, you're going to have to sell your farm, essentially. And that's usually doesn't go well, that conversation. So you need to understand what they're going to do. The fracture can't be fixed in your hands with ORIF. Or if they have pre-existing significant arthritis, that's actually not that common, but it does come up every now and then. And again, the age means nothing, but there's some ages for you. They mean nothing. So this kind of a patient with a capitellar trochlear fracture, she's 82, very sedentary. You know, that is a fixable fracture, but the real question is, what's the risk-benefit ratio in a randomized trial? What would she do better with on average? And on average, for me, that gets a total elbow replacement at that age, because even though I can put screws in there, that often doesn't heal at that age. So she was treated with a paratricipital approach. You're going to need a linked total elbow. These are the 3 common linked available total elbows, I believe, in this area. And so I don't think it matters what linked total elbow you do for this population. I mean, you should just use the elbow replacement that you're comfortable with. And there's no data saying one of these is better than another. There's actually not a lot of data on any of these implants because they're kind of newer. This was treated with a linked total elbow, and she's here at 4 years doing really quite well. 92-year-old, T-condylar, yeah, I can fix that, but I probably really shouldn't, because I can do a total elbow quicker and then the complication rate will be lower. And so here she is all dressed up back in the clinic at 3 months, living at home. She still has her own house at 92, and for her, getting this fixed and getting her going was really quite helpful to her, because otherwise she'd be in a nursing home. So if you actually look at the cost effectiveness of that and who's going to pay for the nursing home and those kinds of things, it actually makes sense, just like fixing a hip fracture, to actually fix this, get her out of hospital and get her functioning again, even though she's got, you can see some heterotopic bone, which has limited her range of motion. Another example here, 82-year-old. She's actually got an olecranon fracture, which you can see on the CT scan, but you can't see on her plain films. So we actually put a plate on that and then put the total elbow in on top of that. And again, this is certainly something I've been observing. These patients actually do get some heterotopic bone. Here's some in the back, which did limit her range of motion. So what's the evidence for this? I think the classic paper that always gets quoted is Mike McKee's paper, and this was a randomized trial, multi-center, including UBC, Toronto. We didn't participate because I wasn't comfortable with the age of 65. I thought that was way too low, and so I couldn't consciously participate in the study, which I feel bad about, but I said, Mike, I just can't do that. I don't know what happened with the study because it turned out their average age of their patients was 78. So I'm not sure what happened to all the 65 to 75s. I think there must have been a change in protocol to avoid that group at the end of the day, but they randomized 42 patients. As you can see here, they allowed crossover. So at surgery, 5 of their patients they actually couldn't fix, so they converted them intraoperatively to a total elbow. This was analyzed, however, on an intention to treat principle. And of course, you can see people do die with this fracture. And it's interesting that every time interval, the total elbow does better with their elbow performance score. In terms of reoperation, total elbows, they had one stiff elbow that required release, heterotopic ossification, and they had one infection. And this is really the disaster one here, right? Because this, you choose to have their stiff elbow fixed or not, and that stiffness happens whether you have a total elbow or an ORIF, but it's this one infection that really goes, oh my God, that's really a bad problem in someone that's 90. Now you're doing a 2-stage revision total elbow. That's not good. But of course, if it doesn't heal, then that's also not good. But of course, in this population, they were expert trauma surgeons. They did all unite. However, they did have some issues and hardware coming out and things like that. And one of them was a non-union required revision. But these aren't easy total elbows to do, and you probably shouldn't do this as your first total elbow out in practice if you've never seen a total elbow in your residency. So and this is something that these are not easy cases. This is a case I did early on in my practice, and you might notice the humeral component is not sitting within the humeral canal, and that's because as I put it in, it went out the back of the humerus, and so this is of course a straight stemmed prosthesis, as they usually are. So sometimes you have to bend the prosthesis if the patient has a narrow canal. And the other thing I've learned is you shouldn't hammer the prosthesis in the elderly patient. If you can't push that stem in with your hands, you shouldn't put it in. And so you want to make sure the cement's nice and soft when you put the stems in. And the other challenge with this implant is you have to put both stems in at the same time and link it. It's kind of a little bit hairy, but the newer implants I think have different ways of doing that, which make it a little less concerning about trying to put them in quickly. But these patients, do have trouble with surgery, so it's not necessarily an easy total elbow for those of you that have never done one. And the other thing is these patients come back. This is my patient. I thought, well, she's 73. She's got a fragility fracture. I'll just put a total elbow in. But here she is. Now she's 78. 5 years later, and her bearings are worn out. And her elbow needs a revision. So be careful who you put this in. So she was too young, as it turned out. The other thing is these patients fall again, because just like someone you do a total hip or a hemi for distal for a femoral neck fracture, they fall down again. They get periprosthetic fractures. And here's a lady that had a periprosthetic fracture of her elbow. She came into the clinic relatively miserable because the component was coming through her skin over there, and these patients don't go away. So if you do the total elbow, you need to be prepared to deal with the consequences. So select your patients carefully. If there's someone that's maybe living on the streets of Seattle, maybe they're not the best person to have a total elbow. This lady has a mental health issue, which is very challenging, and she should never have had a total elbow because she drinks regularly and falls down. I didn't do it. I did take it out though. So what's the advantage of a total elbow for distal humeral fracture? There's certainly no question. More rapid return to function, that's well shown. The short-term outcome is better, but really it's the long-term concerns that we worry about. Complications are less common if you do a total elbow, but they can be more severe than ORIF. And I really think you need to select your patients because of the issue of loosening and wear. What do I think are the pearls? Obviously, choose the right patient. you want to be relatively rapid with your surgery. So, don't try to fix the condyles because you think they might contribute to stability and reduce wear. That's never been shown. So get rid of the condyles. Anything that's busted, just throw it out. Get it out of the way. And put your stems in. Be efficient with your surgery to try to reduce your infection risk. This should not be a total elbow that takes you 4 hours. You really want to get in and get out. I think it does matter how long the surgery takes. Why is the infection rate from a total elbow in our institution still twice a total knee? It's just because the elbow's open longer. People say it's because the skin's no good, but I think it's just the elbow's open too long and it's up in your face while you're operating on it. So you really want to be careful what you're doing in terms of burrs and stuff flying around, and you want to get in and get out. And you want to be gentle with your surgery. Let's say put the hammer away, push the stems in, and that's from experience. And the other thing I've learned is don't move the elbow. Just keep it still until the skin heals. These patients get their range back. The last thing you want to do is rush their range of motion because you think it's going to matter. Keep them quiet. The other thing I wanted to talk about this morning, not to say that you have it available here, but I do think it will come, and I do think you need to know it as an option. Patients may ask you about it because they'll read about all this stuff on the internet. Even though it's not currently available in America, the distal humeral hemiarthroplasty is available worldwide. And again, I'm not trying to advocate it here because I'm not allowed to do that because it's not approved by the FDA, but I would like you to know that it exists so you can have a conversation with your patients if they ask you about it. So it's essentially the same patients that are going to have this that get a total elbow. They're fit enough for surgery, but maybe they're going to do a little bit more than you'd like, right? So these are someone that you really don't want to do a total elbow, but you can't actually fix their fracture. So that's kind of the interim group. So for us, this is a very small percentage of the total elbows we're doing are getting a hemi. It's probably around 10% of patients that we're treating with an arthroplasty are getting a hemi in our institution. So it's a very small subset. I don't think they should be used in old people that are going to, that the total elbow will outlast them. So this is the kind of younger group. They can't have too much arthritis. I don't know what the age range is. Again, it depends on the circumstances. What's the advantage of a hemi? No polyethylene, nothing to wear there. It's less invasive. You don't have to put the ulnar component in. Putting the ulnar component in is the hard part in doing a total elbow for a fracture because, of course, you don't want to take the triceps off, so you're always struggling to get the ulnar component in, whereas putting in the humeral component is dead easy. You just take off the condyles, shove it in, cement it, and you're kind of done. But it's actually the ulnar component which is the hard part. So it's a bit faster, it can be, but not necessarily. It has a role in all younger patients not suitable for total. We also use it for non-unions and AVN. But this isn't a new idea. People say, well, that's a new idea. This is an 80-year-old that had a hemi done 50 years ago at our institution. He kind of came in. Why did he come in? Because he fell and he cracked through his olecranon back there. Now, his elbow hasn't moved for 50 years. Actually, why it hasn't worn out, because it's essentially ankylosed from bone. But he actually had this done 50 years ago when he was in his 30s. And now it's there 50 years later. So it's nothing new. In fact, it was started off in 47, and there was a number of different versions have been available all the way coming down. I think this was an anatomic implant that was designed to fit correctly. So Street and Stevens and Charlie Sorby's total elbow is very anatomically shaped, so it was used as a hemi, including in America before they were taken off the market. And then some people have used non-conforming implants, like the capitellar condylar was used as a hemi, but again, it doesn't really fit well with the distal humerus, so maybe not be the best choice. So this is the hemi we're using. It has 6 different sizes, so it's a little different than the total elbow. It's got lots of articular sizes, so it's a little more like a hip hemi where you got lots of different ball sizes. And for us, there's different ways to do it. Some people use an olecranon osteotomy. I typically will do a paratricipital approach. It's important to get the components in the correct orientation and position, and you need to actually get the condyles to heal. So it's not just about putting the hemi in. A hard part of doing a hemi is restoring stability. So you need to fix the collateral ligaments or fix the bone or both. And so I'll show you some examples of that. So this is a lady we might consider for a hemi in our population. She's 71. She has known severe osteoporosis. And you might say, I can fix that, and maybe you can. We kind of went in with a double setup like we talked yesterday. We had a look at this, and after some discussion, we ended up doing a hemi. So we took all the bits out. As I say, putting the hemi in, that's pretty easy, right? I took a couple of saw cuts and it's in. It's important when you put the hemi in to get the rotation correct. And what are your landmarks for rotation when you don't have epicondyles? You use the flat spot of the posterior humerus and you internally rotate the component about 14 degrees. If you put it parallel to the flat spot, it's malrotated. And that's important because malrotation probably causes wear. The big problem here is you've got to do column reconstruction. So you put in the hemi, so you just going back, you put that in, but that's actually that was the easy part. You know, I usually let the resin do that part for sure, right? And then the hard part is, well, how do I get this epicondyles to fix? So you actually have to plate them or tension band wire them or suture them on, but you need to actually fix them. And so you get to do an RIF too, which is kind of fun. So you get to put the hemi in, then you get to put your plates on, so that's kind of neat. And so in this case, we still use plates sometimes, and sometimes we use tension band wires if the bits are small, but again, this can work. Another example here of a bad distal humeral fracture in a 74-year-old. Again, you know, she's pretty active. I don't really want to do a total elbow in her, but after looking at this, we really didn't think we could put this together. So again, a paratricipital approach, take all the junk out, and here she is with a hemiarthroplasty. Now in this case, because the fracture is so low, we were able to actually just suture the ligaments. This implant's got a hole through it where you can suture the ligaments to it, and so that's actually worked pretty well. She's now about 4 years out. She's got a little bit of subsidence into the medial trochlea, which is the biggest thing we're seeing at medium-term follow-up with this, but again, she's got quite a reasonable functional outcome. What are the results of a hemi? I think there's 2 useful papers for you that exist and aren't just a small case series. This is the one from Jeff Hughes in Australia. He had 17 patients with a good amount of follow-up. He was pretty aggressive. I mean, his mean age was 62, so he was definitely using them in difficult fractures in younger patients. Again, I would be tending to fix probably more of those, but again, the outcome scores are good. It's kind of like all the distal humeral fractures are all about 90. He had 2 revisions for loosening, 2 periprosthetic fractures because patients fell again, but no instability, but he did note ulnar wear in 13 patients. Now these were 2 different types of hemis he was using. It was both the Latitude as well as the Sorby in that series. And the latest papers from the British Journal, 42 patients, again, with short follow-up, but the similar kind of outcomes. They had 1 loosening, 4 patients got stiff, and 1 had some instability, and they noted some ulnar wear in 5 of the 42. So it seems like, at least in the short term, this is okay, but it's probably going to be kind of like the discussion about for a shoulder. You know, you've got a difficult 4-part proximal humeral fracture. Who's going to be better? Someone gets a reverse or someone that gets a hemi? Probably in the short term, it's going to be the person that gets a reverse, but that doesn't mean that I would want to reverse at my age right now. I'd probably take the hemi. But I know, of course, you do more hemis here than other parts of America. So I do think it's something to consider, but right now it's not available, but hopefully it'll come soon. I think there are some things that we've been looking at in the lab, and you'll see some stuff published on this in the journals coming, and we've just published, but I think we probably need to get the shape a little bit better. This is the shape of the Latitude, and you can see we looked at some of the contact forces that occur across here, and you can see the wear even in the cadaver of this ridge here after biomechanical testing. So we've actually done some work on reverse engineered implants. So these are reverse engineered. So you take a CT scan and reverse engineer the articular surface, and you can do that just like you can do it for the hip or the knee. And so that kind of may be the future. I think it's interesting that when we've looked at our studies on this and compared the contact pressures of a reverse engineered and something off the shelf, it's not that different. And it's really, the problem is we need a more compliant hemiarthroplasty. And that's going to be the holy grail, is to come up with a shape that's not only anatomic and put in correctly, but the surface has to be a little less stiff if you expect the cartilage not to wear out over time. So every other hemiarthroplasty we know wears out over time. So this is a group that will wear out over time. It's just a matter of who, what beats the race. So, I think we're doing some work on trying to improve the shape matching and probably improve the material over time. So what, in summary, I think you want to think when you're treating someone with a distal humeral fracture to remember non-operative treatment. Have the discussion with the patient. Have the discussion with the family before you just go ahead and say, I'm going to fix that, I'm going to replace it. Make sure they know that's an option, because they may choose to select it. And, you know, if it doesn't heal, you can always do a total elbow. So it's not like, you know, prevents you from doing that. There's no question that doing a total elbow early is easier than if you let it get a non-union and fix it, but it's still not a huge difference. It's different if you fix it and it falls apart, as was mentioned yesterday. I think the ORIF is successful if you select your patients well and do the technique well. I think total elbow is here to stay for these fractures, and I think given the aging population, I think Seattle's probably a bit different than where I live. When I look around, the people tend to be a little younger and more active, but I can tell you where I live in Ontario, we're all getting pretty old, and this is a big problem for us in our region and in terms of managing these patients. And I think Hemi is kind of interesting. Obviously, you can't use it. Some people always ask me, well, can you use a different total elbow for a Hemi that isn't approved? And I don't think you should. You know, I don't think you should take the Latitude, for example, has a spool which is not the right shape for a hemiarthroplasty. You shouldn't use that. I don't think you could really, if it doesn't work out, I don't think you're really covered for that, so to speak. I think it's the wrong thing to do. So if you're not allowed to use it, then don't use it, right? So because I think you need a shape that actually fits the patient if it's going to be durable over time. Thank you very much. Any questions? Have time? I don't know if we have time.
So, the obvious question for me is, can I convert, and how difficult is it to convert that Hemi to a tool?
We don't have a lot of experience. I've done one conversion. That was in someone that I probably shouldn't have done the Hemi on. It was someone that had a distal humeral non-union. We just didn't have enough lateral column. So we did the Hemi, worked out perfectly, but we couldn't get stability. The lateral column, we did bone grafting, but it dissolved and he got instability. So actually converting it to a total's pretty straightforward in the system. There's a screw, it's a modular implant, so you take the screw out, you take the spool off, and you put the non-anatomic spool on, put the screw back in, and then you put an ulnar component in and link it. So it's, you know, of course the elbow's scarred up and you got to wonder where the nerve is and all that stuff, but specifically you don't have to take the stem out to convert it. So that's kind of one of the design features that we were looking for when we developed the system.
And just the mechanics of you doing a total elbow, you do a lateral approach, right?
In terms of positioning?
Yeah. You do a supine, and then your approach is disarticulation through sort of a lateral approach. Is that true?
My surgical, well, I do the patient supine. Which I prefer in the elderly anyway. So typically when I do a distal humeral fracture, if I've got enough help, I prefer to do a supine position as opposed to lateral acubus. I think the elderly tolerate that a bit better. And in terms of how I do the surgical approach, you can either do it with a paratricipital. Currently we actually use a lateral paralecranon approach, which we published in the Journal of Hand Surgery a couple of years ago. So basically you take a Boyd approach, cut along the edge of the ulna and split the triceps and fold it out that way. The advantage of that is you get a much better look at the ulnar canal to position the ulnar component. And it does, you know, you can do it with a paratricipital, but I think for people that are learning a total elbow, it's a hard thing to get the ulnar component in, no matter whose system you use. This is generic, this discussion. It's hard to get the ulnar component in the correct position and orientation, and that's the biggest single cause we think of wear and early failure of total elbows is the ulnar components incorrectly. So you throw the epicondyles out, have an approach where you can see the ulna. I prefer the lateral paralecranon approach, and then you instrument prepare the ulna.
To that end, even though you're using that lateral paraarticular approach, you always decompress the ulnar nerve, right?
Correct. I'm still scared of that thing after all these years. Yeah, it can get wrapped up in things and drills and burrs and yeah. Yes, sir.
Question: in your study where you looked at non-operative management, there was a small group of patients that went on to non-union.
Yep.
Did you find those patients did poorly as well, or did they do worse than the people that healed?
Yeah, they had a poorer outcome than those that healed. But you know, most of them actually never had another operation. Yeah. So again, the mortality rate in that subgroup I didn't actually present the whole paper, you can read it, but basically that's a hard study to do as a resident, because every time you call, well, you know, Granny passed away last year, you know, it was kind of hard to get people to come back because, you know, it had about a 40% mortality rate, right? So these are patients that we thought were really sick and we didn't want to operate on them, right? And so when you tried to follow them up, it was kind of hard to get them, you know, we had to, you know, one of our fellows did, he actually went to the nursing home, some of those pictures from nursing homes, because the patients couldn't come in, right? So, you know, you have to kind of, it's a tough study to do.
And then the other question that comes up is that you'll be in panels of people that are as good as you, and there will be the implied statement that if somebody is treated with ORIF and it fails, you can convert them to a total elbow. Now, in that group of patients, is your outcome for those total elbows the same as if they had just had a total elbow?
You know, I think that there's not that much written about it because the numbers are small, but I think you and I would both agree, and I think it's also true in the proximal humerus, the hip. You know, you take a shot at something, that's not free, right? It's not free to the system and it's not free to the patient. So you go back there again after, and you got to take a bunch of plates off and do a total elbow. That's a hard operation, even for me. You know, I'm not saying I'm particularly good, I just do one thing. So if you just do elbows all day, you don't have to be very good. You just have to, you've seen it all before, but you know, getting those plates off and you got holes everywhere, right? And then you're trying to put cement in, the cement's spewing all over the nerves, which is what it does, by the way. It spews all over the ulnar nerve, and if you're high enough, the radial nerve, so you got to make sure it's not there. And you don't get good cement technique, right? And why has it failed? You know, maybe they're infected and you don't know that, so infection rate's higher. Soft tissues are taking a hit. Where's that ulnar nerve anyway? You know, so, you know, the complication rate's night and day. Night and day. I think the complication rate of a non-union that hasn't been treated surgically to a total elbow, it's a little worse than doing a total elbow right out of the chute, but it's only a little bit worse. But if you try to fix it and it falls apart and you're converting it, that's a high risk procedure. Not only high risk technically for you as a surgeon, but for the patient, the soft tissue envelope, the risk of infection, it's all night and day. So I do think that early discussion with the patient is quite important. You can't be faulted on your board exams to treat an elderly patient that's low demand, that's got dementia non-surgically, that's okay. After you discuss that situation with the patient, their family, and let them try to decide themselves. They'll often ask you, what would you do if it was your mom? That's the way I think about it. But, you know, it's an important discussion to have because it's different than a hip fracture. It's different than someone with a femur sticking through their, you know, quadriceps muscle. That's an easy discussion in the trauma room. This is a bit harder discussion because patients do have choices, and those choices may affect their future. Yes, sir.
When you're casting people, how do you decide when to take off the cast? Are you seeing them every week? Check them?
Yeah, it depends on the patient. You know, we have, you know, some patients are quite able to tell you something's wrong. Some patients are maybe you're a little less sure. Some patients are pudgy at that age, and some patients are bone racks. So if you're super thin, then I see them more commonly. If I'm a little bit worried about their ability to be compliant, I see them more commonly. Certainly I see them at week 1, probably week 1, 3, and 6 is probably the way I go in most cases. But if I'm concerned at week 1, I might see them at week 2. It depends, you know, it's just your clinical guess. But I think you should also tell the patient and their family if the cast is getting loose and bouncing around, call me and come in, right? So you tell, you know, empower the patients and their families to say if there's a problem, just let me know. But it's usually the family you need to have that discussion with as opposed to the patients, because these patients are pretty stoic. And we don't worry about what the x-rays say, to be honest with you. We don't, you know, if it's at 6 weeks and it doesn't look united, well, you know, I'm not going to cast them for 3 months, right? So it's usually somewhere between 6 and 8 weeks. You can see someone treated with 8, some 6. I'm kind of settled more or less on 6 now based on our experience and our data. So basically at 6 weeks, the cast comes off, and what happens is what happens. That's the way I think about it. And so they'll either unite or they won't. But we don't send them to therapy at 6 weeks. No. So these patients do not see the therapist usually at all, but certainly not before 12 weeks. It's amazing that they just start using their arm and it just kind of works. It's an interesting thing. Yeah.
So the other thing that's coming out a lot is about volumes, right? If you look, lots of data from hip fractures showing, you know, people people who do at least 25 a year and have better outcomes than nonetheless, right? If you look at volumes, right? Hip fractures, shoulder fractures, and total elbows, I mean, again, you're looking at volume. So the question is, if you're looking, I've fixed probably 5% of these a year total. I've never put in a total elbow. So the big question is, what do you tell the communities and everything? I think that's great. You're in an expertise center. Now you're looking, so does your advice change for example, communities where you're doing these elbow fractures? Should they just say, let's say they're getting in there and they're doing an ORIF and they can't get it fixed. Is it better than at that point just to say, stop, close up, and then send it to someone who does lots of total elbows? Or do you want the community guy putting in one a year?
Well, that's a difficult discussion because, of course, there's community factors. Patients may not want to come here from, Yakima, right? They may want to go across the pass in the winter to have, you do their total elbow, right? So, sometimes patients drive you to do things that maybe you prefer not to. I think if you're uncomfortable, and I would say that to the residents, if you're ever uncomfortable doing an operation, don't do it, because it'll just hurt you and the patient at the end of the day if things don't work out. There's no question that the data shows, just like every other thing, for total elbow replacements, high volume centers have less complications. That's well documented, and in fact, the lawyers will use that against you. If you do a total elbow for a fracture, and that's the first one you can demonstrate you ever did in your career, and something terrible happens, that actually can be used against you. So that's something to consider when you're making a decision. I don't think that I'm any better as a surgeon than any of you guys and girls here, but I've probably done more total elbows, so I probably made those mistakes as I showed you. So, I'm probably going to have a lower complication rate than someone coming out of residency that maybe saw one in their residency and now they're kind of doing it. So I think that's a decision it's hard. Maybe at some point the government or our insurance companies will make that decision for us when we should do surgeries or not. Maybe that should be concentrated. Certainly in Scandinavia, that's mandated. So all the total elbows are done at higher volume centers. I think there's 3 in Sweden that are allowed to do a total elbow, for example. The other centers just aren't allowed to do it. We're not kind of like that in Canada yet. I think it's like probably the same thing for some of the things you guys do here, like, spinal disc replacement. If you do one of those a year, you probably shouldn't be doing it, really. That's my thought about it. So again, for a total elbow, maybe if you're not doing one every year, then you probably shouldn't be doing it. Maybe you should phone a friend. Most of us, at least north of the border, even in working in community hospitals, most people have a subspecialty interest now, and I think that's probably true here as well. So if it's coming into you on call and you really aren't comfortable treating it, I would say don't. This can wait. It doesn't have to be done the night of. Even if it's an open fracture, you can debride it. Don't put X-Fix on it, please, and splint it, and it can be done within a few days by someone that really wants to do it. So I don't like to tell people not to do things, but I think you should think about it, because, if something doesn't work out, you're going to feel terrible. And that's happened to me. I've done something that, didn't work out, and maybe the patient dies. You're going to feel really terrible about it. And so you don't want to be in that situation, particularly in your first few years of practice where you're just trying to make ends meet, because people hear about things and talk, whisper in the halls. So you want to kind of do the right thing when you're out in practice.
You talked about your management of patients after ORIF. After your total elbows, do you splint them in extension too?
Yes.
Until their skin heals? Do you ever have them see a physical therapist?
We do, but we have the physical therapist basically function as a teacher. We don't think that patients with a total elbow need to come back and forth to see the therapist, particularly in the elderly population. I think it's a waste of time, money, resources. If we're concerned about the skin at week 2, we'll still maybe give them a nighttime extension splint, and then they'll have a collar and cuff in the day, and we just teach them to move their arm. There's no restrictions after this wound heals with the approach I do. I don't say you can't use a walking aid. We let them use a walking aid as soon as the skin heals. And so it's really that first 2 weeks that is the big problem. In the elderly, I mean, if you're used to taking the triceps off to do a total elbow, you should not do it in a patient with a distal humeral fracture because patients that are older cannot get up out of a chair unless they use their triceps. So, and I can say this from experience, do not take the total triceps off because they'll rip it off. And if they rip off their triceps after total elbow, they will be very unhappy because they won't be able to get up. They can't use their walker or their cane, and the outcome is not good. So do not detach the triceps in someone that you're going to do a total elbow on.
So it's the same thing as what you talked about yesterday. Do you use fiberglass for those patients, or do you use plaster?
Plaster. Sorry, excuse me, fiberglass anterior slab. Yeah, so it's kind of light, but they all say it's huge, and you know, they're very unhappy, to be honest with you, the first 10 days, or 2 weeks, whatever you're going to use it, because they really are kind of like got this peg laying on their arm and they can't do much. So that period, they often require some support. They may not be able to actually go home if they live independently, depending on their resources. So that's relevant. But I think it's, for me, it's been a game changer with the wounds. It's a game changer because I was trained by Bernie and, you know, to move them right away. I think that's not a good idea. I really don't think it's a good idea. And the data from our group says it doesn't affect range of motion to wait. So wait.
Great. Well,
Thank you.
We'll transition to our presentations.
Just before everyone goes, I just kind of want to make a comment. You know, I've, as we talked last night, you know, I've been to a few of these visiting professors things. I just want to congratulate while some of the consultants still have their residents for what a great job you've done, you know, with your organization and preparation of the cases. I've never seen that before in any visiting professorship I've ever done. I mean, the organization of those cases, you know, the case number 2, everyone's got their own case. It's so well prepared. I think it really is a testament to the effort you put into the program and to the people that train you. So congratulations to you for that effort.